Top Bed Talk.
I'm an anaesthetic registrar in London, and my research interest is in how human cells produce energy, how this changes in response to stress, and how this may influence survival. As anaesthetists, the ultimate goal of almost all of our interventions and monitoring is to support cell energy production, to provide mitochondria with the oxygen and the fuel they need to produce enough ATP to power cell function and integrity. In intensive care medicine, the potential benefit of a less is more approach to these interventions has become increasingly apparent, with a shift towards more permissive targets for oxygenation, ventilation, hemodynamics, and feeding. In this Goldilocks session, I've been asked to consider the relevance of a less is more approach to nutrition in the perioperative period. First, I'd like to stress that I am not a dietitian, nor an expert in enhanced recovery, and the next 20 minutes will not be a pragmatic guide to perioperative nutrition, to which I refer you to the evidence-based international recommendations by the Perioperative Quality Initiative Workgroup and by the European Society of Perioperative Nutrition, which were published very recently. Instead, this is supposed to be a provocative, question-generating session to provide food for thought. I'm going to explore concepts, including metabolic capacity and trade-off, biological stress, and cellular adaptation, and how these might apply to the biggest planned stressor that most people will face in their lives, that of major elective surgery. So energy is produced by the oxidation of macromolecules from food, carbohydrate, fat, and protein, to extract electrons for donation to the mitochondrial electron transport chain, and drive a series of redox reactions, which ultimately consume oxygen and produce ATP. Energy production therefore depends on this vast network of interdependent metabolic pathways. As well as energy, these metabolic pathways are also responsible for providing the building blocks of functional molecules necessary for survival, including enzymes, proteins for structure, muscle contraction, and immunity. The rates of these reactions are influenced by the concentrations of various substrates, including oxygen, inhibition by end products, and the activity of inducible enzymes. The network is subject to alteration from signaling pathways, including hormones, cytokines, and redox changes. A change in demand or supply in one part of the pathway may have an impact somewhere else in the network, creating a metabolic trade-off between one function and another. Take, for example, what happens as a result of surgery. In the perioperative period, several different stressors independently impose a deviation to the metabolic network. Both fasting and immobilization trigger a catabolic state, where substrates such as glucose, free fatty acids, and amino acids are mobilized from longer-term stores, glycogen, fat, and skeletal muscle, in order to provide energy. Fasting and immobilization also inhibit the actions of insulin. Surgery itself is superimposed on this state. Tissue injury triggers a systemic inflammatory response, the acute stress response, which increases the demand for energy and protein, for tissue repair and the immune response. This also triggers a catabolic state in proportion to the degree of tissue injury, and it also induces insulin resistance. So collectively, the metabolic alterations that occur in the perioperative period can impair recovery through the development of insulin resistance, which is known to be associated with the development of postoperative complications such as wound infection and sepsis, but also the development of a protein deficit, which causes muscle weakness, which delays physical recovery and increases the risk of thromboembolism and pneumonia, Protein deficit also limits the immune response and the ability to repair tissue. One approach that we use to reduce harm from the surgical stress response is to minimize the stress itself through adopting minimally invasive surgery or optimizing our anaesthetic with analgesia and the use of regional techniques. Another approach is to supplement nutrition perioperatively to increase substrate reserves to meet the increased metabolic load posed by surgery. This is particularly important in patients who are malnourished to begin with. We know that malnutrition is a major risk factor for adverse outcomes after surgery, and we know that it is very common in surgical patients. It's for these reasons that current guidelines advocate minimizing the additional catabolic stress imposed by fasting in the perioperative period. They also advocate screening for malnutrition and providing targeted pre-operative nutritional therapy to provide the energy needed for the immune response and repair processes, and to prevent a calorie and protein deficit leading to muscle loss and impairing functional recovery. They also try to prevent insulin resistance through carbohydrate preloading. And there's strong evidence from randomized control trials that all of these interventions, both individually and as a bundle, improve outcomes in surgical patients. So how can all of these facts fit with an argument for a less is more approach? Well, there are several reasons. The first is that augmenting substrate supply during times of stress does not counteract muscle catabolism. Because in this instance, catabolism is being driven by immobilization and the stress response, and is actually insensitive to the anabolic effects of nutrition. Secondly, several of the pre-existing metabolic malnutrition phenotypes that are common in surgical populations are not amenable to improvement by nutrition alone. For example, sarcopenia is related to aging and inactivity. Cachexia is seen in cancer and chronic inflammatory conditions and is also multifactorial in origin and may be related to cancer-induced metabolic changes and inflammatory signalling. The third reason is that human cells have the capacity to adapt to stress, including increased energy demand or limited substrate supply. So recovery from surgery may also depend on this cellular capacity to adapt to stress, not just our efforts to minimize the stress response itself, or our attempts to exogenously supplement substrate supply to meet the increased metabolic demand. The question is now, can we actually promote cellular adaptive capacity? So one approach may come from animal studies. Animal research has consistently shown that caloric restriction improves lifespan. In human populations, long-term dietary restriction has been associated with increased longevity and lower levels of metabolic diseases. But more recently, it has been recognised that dietary restriction also induces cellular changes which confers increased resistance to multiple forms of acute stress, and that this adaptation can be induced rapidly. How does this work? So the mild stress of nutrient and energy deprivation triggers a cascade of systemic and cellular changes. This includes reduction in sympathetic tone, inflammation, and oxidative stress, all features of the surgical stress response that we think increase harm perioperatively. They also trigger cellular, repair, and survival processes, including upregulation of mitochondrial function and biogenesis, antioxidant defenses, and autophagy, to remove damaged molecules and recycle their components. They also decrease the demand for overall protein synthesis and cellular metabolism. So could this metabolic preconditioning improve surgical recovery? So I have to emphasize that the majority of this research is limited to animals and must be treated with extreme caution when applied to human populations. The figure here shows the potential cellular mechanisms of protection from surgical stress due to dietary preconditioning. The figure shows how protein or even specific amino acid restriction will activate nutrient and energy sensing signal transduction pathways. Now, the downstream actions of this are to activate signaling pathways including AMPK and SIRT1 and inhibiting the mTOR pathway. And this has downstream effects which increase insulin sensitivity, activate pro-survival signaling, and increase the production of hydrogen sulfide, which can protect the cell through multiple direct actions, including as an antioxidant. This figure is a model of how metabolic rate changes over the perioperative period, and hypothesizes that by reducing overall cellular metabolism, metabolic preconditioning may reduce the patient's metabolic demand at baseline, as well as the metabolic load in response to tissue injury. And we see this as the dotted line. Again, this is an evidence-based perioperative medicine conference. We have to emphasize that we do not actually know whether dietary restriction does dampen the stress response to surgery and to what extent this would affect surgical outcome. So what is the evidence? So the benefit for surgical patients remains theoretical. We know that short-term, as little as 2 to 4 days of dietary restriction has improved outcomes in preclinical models of surgical stress, including ischemia-reperfusion injury to the heart, brain, liver, and kidney. This highlights the potential benefit in surgical procedures where blood flow is interrupted, and for post-surgical complications like heart attack or stroke. We know that short-term dietary restriction has been shown to be feasible and safe in patients prior to living organ donor surgery and in chemotherapy. In fact, dietary restriction is the standard of care in bariatric surgery in order to reduce the liver mass and facilitate the surgical procedure itself. How might we induce these adaptive changes? So the dietary restriction must be sufficient to cause depletion of liver glycogen stores, such that free fatty acids are released into the circulation and converted to ketone bodies. It must inhibit insulin activity and the uptake of glucose and amino acids into the cells. And it is collectively these changes which signal the nutrient and energy stress and induces the cellular changes that we've discussed. How much restriction do we need to activate these changes? Well, in rodent models, it has been achieved by restricting overall food intake by 30 to 40%. But benefits have been seen up to the cusp of starvation, a 60% calorie restriction. Clearly, this is not very feasible in surgical patients. One solution to this problem is the specific restriction of protein and not carbohydrate or fat, as protein disproportionately triggers metabolic preconditioning, even without total calorie restriction. So diets specifically lacking in individual amino acids, such as methionine, may even be enough to trigger the changes through its effects on insulin signaling. In fact, readdition of methionine has been shown to prevent metabolic preconditioning that has been achieved by dietary restriction in a mouse model of hepatic ischemia-reperfusion injury, probably because of a reduction in hydrogen sulfide production. Another potential solution is by intermittent fasting, so limiting the time period in which calories are taken into the body. In the typical Western diet of 3 daily meals and snacks in between, people rarely, if ever, reach a fasting state. After about 10 to 14 hours of continuous fasting, liver glycogen stores are depleted, and the fasting state can trigger metabolic adaptation. What's more, on feeding after this prolonged fasting period, the combination of rising glucose levels and falling ketones now signals growth and repair and protein synthesis. And an intermittent feeding fasting regimen results in repeated metabolic switching between the two states. And it is this which confers longer-term adaptations that improve insulin sensitivity, cardiovascular and autonomic function, and reduces inflammation. Again, all likely to be positive in a perioperative setting. What's more is this signalling is enhanced when it is combined with exercise. Like most vital functions, metabolism follows a 24-hour or circadian rhythm, and unpredicted food intake, for example eating at night, has been associated with the development of metabolic dysfunction. It is possible that the benefit from metabolic preconditioning might therefore depend on the time of day that feeding or fasting occurs. So clearly much work is required to work out the dietary restriction protocol that would trigger the optimal stress response for surgery. We need to know how many days it takes and information about the diet itself in terms of total calories or the relative composition of protein, carbohydrate and fat. We need to know about fasting and feeding times, including times of day, and we need to know about the additive benefits of combining these programs with exercise programs, which have already shown to create huge benefit in the perioperative period. We need to know the influence of the type of surgery or patient factors, including their pre-existing metabolic phenotype, whether it's obesity and diabetes or sarcopenia and cachexia. We also need to be cautious. Long-term dietary restriction in rodent models has been associated with impaired wound healing and immunosuppression. And although this is different, starvation is different from short-term dietary restriction, this is clearly something that we need to work out. At first glance, dietary restriction to improve surgical outcomes seems entirely at odds with our current guidelines on perioperative nutrition, for which there is clear clinical evidence of benefit. However, both approaches are consistent with the concept that the catabolic response to surgery is harmful. They just use different strategies to combat it. Arguably, the biological rationale for the dietary restriction approach has some advantages over pre-operative supplementation. Because we know that neither perioperative catabolism nor certain malnutrition phenotypes like cachexia and sarcopenia can be reversed by nutrition alone. Meanwhile, the metabolic preconditioning triggered by dietary restriction may protect against many different aspects of surgical stress. But we must be cautious in our inferences from animal models and be cognizant that with its emphasis on both calorie and particularly protein restriction, dietary restriction is the polar opposite of the current approach for which there is a strong evidence base. We need a greater understanding of how nutritional factors, not just quantity, but substrate type, relative composition and timing, interact with perioperative stresses and pre-existing metabolic phenotype to influence clinical outcome. Perioperative nutrition could less be more. We really need a deeper understanding of the safety and efficacy of preoperative dietary restriction, particularly in malnourished patients. I'd be very happy to answer any questions, and I'm available at this email address.
Top Med Talk. Thanks for downloading Top Med Talk. Don't forget to subscribe via your podcatcher. Don't forget to check us out on social media. We're on Twitter, Facebook, LinkedIn, and YouTube. And also, don't forget, Top Med Talk is the broadcasting arm of EBPOM, Evidence-Based Perioperative Medicine. We'd love you to find out more about that. If you check out ebpom.org, you can find low prices on some of the conferences we're organising around the world. Many of them are virtual and don't even involve you leaving your own home. Check out ebpom.org now.